Welcome back, everybody, to the second of today's digital. Again, my name is Stephen McCollum. I'm your host and MC today, and thank you all for joining us. For those that did not join us for the first webinar, and a reminder for those that did, we have 3 ways for you to ask questions during today's program. You can enter them into the box that's at the bottom of your screen. If you'd like to ask your question live, you can click the raise hand button at the bottom of your screen, and I'll call on you during the live Q&A portion of the program at the end of the session. And you can also put your questions in the chat box. So again, 3 ways to ask questions. Put in the Q&A box, use the hand raise function, or put them in the chat box. I do encourage everybody to open the chat box now, because I am going to ask a few questions in there to get the conversation started amongst all the attendees who are participating today. And just a quick reminder, when you're using the chat box, make sure you select that you want to respond to all panelists and attendees when you send your, otherwise it just goes to the panelists and your fellow attendees can't see it. So again, when you're using that chat box, you press panelists and attendees when you want to send a message to the entire participating body. So with that, I'd like to sponsor the program and check out all information on the web. Specifically, a big shout out to Pure Store, to Neuroflow for supporting this particular session that we're on right now. Before we get started, I'm going to go ahead and introduce each of our panelists, and then I'll turn it over to our moderator. So welcome to Dr. Jeff Bailett, who's with Altice, Dr. Pamela Peel with UPMC Health Plan and UPMC Enterprises, Robeson with Brown Physicians, Priscilla Sandberg with Pure Storage, Laura with Neuroflow, and of course our editor-in-chief, Mark Hagland, and moderator extraordinaire. Mark, I'm going to turn it over to you, and I will see you for the day. Thank you again to everybody for joining us.
Thank you so much, Stephen. I really appreciate it. Can everyone hear me well?
Perfect.
Great, thank you. This is such an exciting panel, and I really do want to thank each of our panelists for being with us today. We appreciate you so much, and people are really thinking about the issues that we're going to be exploring. So I'm going to spend 1 minute just kind of laying out what we'll be talking about very broadly. Then I'm going to ask each panelist to spend exactly 1 minute describing their title and their role and their connection to this, because we've got a lot of questions to go through. So I know everyone will be very disciplined about that. So we're going to talk about pair-provider collaboration today. And it's a fascinating subject because what's happening now finally had been predicted really for decades in healthcare, that payers and providers would get to the point where they decided that it was important to be doing this, to be truly collaborating around data, around value-based contracts, and around every area you can imagine. Every one of our panelists is in some way connected to this topic. So what I'm going to do now is ask each panelist to simply introduce him or herself and describe their connection to and their organization, and describe their connection to the topic at hand. And again, I'll ask each panelist to try to limit it to about 1 minute so that we can get to all the topics. We'll go. I'm going to go in clockwise around my little view of our screens here. I always tell friends we're all living in the Brady Bunch world with all these squares and people looking at each other. So I'll go to Jan. No, Dr. Jeff Bailett, why don't you introduce yourself first?
Thanks, Mark. Delighted to be here. Thank you for the opportunity to participate today. So Jeff Bailett, I'm the CEO of Altice, which is a brand new startup or physician services organization. Blue Shield of California is the founding investor in our company. I was formerly an executive vice president with Blue Shield. I'm an ENT physician. Altice is a company that is established to support the physician community with tools and technology, as well as making investments in practices, particularly independent practices, to help them remain vibrant and to make the transition from fee-for-service to value-based care delivery, which is something that we desperately need. Thank you.
Well, wonderful. Thank you, Doctor. Kelly Robison, I see you next.
Great. Hi, thanks so much, Mark, for having us today. Kelly Robison, Chief Executive Officer, Brown and Tollen Physicians. Brown and Tollen is an IPA in the San Francisco Bay Area, comprised of about 2,700 physicians, and we partner with 23 hospitals, service about 355,000 patients throughout the Bay Area. Our organization is actually steeped in value-based care. We are in our 28th year of existence, and believe it or not, have taken capitation as a form of reimbursement for the entire 28 years. So we are comprised of a contracted IPA. We have a small employed group of physicians within Brown and Tollen as well, along with a full service management services organization.
Great, great. Dr. Peel, I see you next.
Hi. First of all, thank you. It's a pleasure and an honor to be here with this panel. It is, I agree, Mark, an amazing group of people. It's going to be a pleasure to do this. I'm Pamela Peel. I'm the Chief Analytics Officer at UPMC on the Insurance Services Division, and at UPMC Enterprises, which is our venture capital and startup. UPMC is a payer provider. We are a $21 billion a year organization. Top line, 12 billion of that comes from the payer side. We have over 4 million covered lives and over 8,000 employed physicians. We own, brick and mortar, 40 hospitals. We have been in this space of payer provider and value-based and shared savings and bundles for well over a decade. What makes us special, I think, is that we are a payer provider, but as an insurance company, half of what we pay for our covered lives for care goes to a non-UPMC provider or facility. So we get to experiment on ourselves and then export it. Thank you again for the opportunity to be here.
Thank you so much, Dr. Peel. Chris Malero.
Thanks, Mark. I appreciate the opportunity to be here today and talk about a subject that's really, frankly, important. And we're just at the, I think, tip of the iceberg in terms of what's to come. I'm the CEO of Neuroflow. We're a technology platform and services company that partners with payers and providers to integrate behavioral health into traditionally non-behavioral health settings, empowering primary care providers and other specialists to assess their populations more frequently and automated, identify rising risks and risk stratify their populations so they can coordinate the appropriate type of care, not sending everyone to the psychiatrist, but providing that right level of care for mental health integration with physical health. We proudly support 350,000 people on the platform today across 37 states. Blues plans, we just announced a partnership with Prudential and the like. So it's an honor to be here and looking forward to the discussion.
Thank you so much. And last but not least, Priscilla Sandberg.
Thanks, Mark. My name is Priscilla Sandberg, and I like to say that I spent my whole career forcing people to provide data. So starting off on the insurer side with claims data, and then moving over to the EMR side, having physicians document. And now that we're at Pure Storage, we are committed to supporting these healthcare clients to make the most of their data. Pure Storage is the leader in all flash storage solutions, which makes reporting, analytics, and giving information back to the providers and the payers one of our highest priorities. So we're happy to be here.
Thank you so much, Priscilla. Thank you all. This is going to be very exciting. So I actually have a list of about more than a dozen major questions. So I think what we're going to do, and I had prepped everyone before about this, I'm going to direct each question at one or two people initially, but all panelists are certainly welcome then to respond. It's just with a very large panel, we could have little traffic jams. So let me plunge right in. Let me start out with Dr. Jeff Bailett, and then I'll go to Chris. What are the elements that are incenting the new payer-provider collaboration in healthcare from your perspective?
Mark, there are several, and it's not one size fits all depending on the circumstances. There's more pressure from the employer community to move to value. The competition is really turned up pretty high, and there are a lot of disruptors in the marketplace, and for plans to remain competitive and to be able to continue to sell their products and build and foster the relationships with the purchasers, they need to provide a high-performing, affordable network of physicians, whether they be independent or through a system. And the plans, for the most part, have historically not been at the bedside. So everything that they do requires influence. And so the plans are realizing that they have to have different, more empowering relationships with the provider community, which is refreshing, frankly. And I think a lot of the moves that you're seeing, Alteus is just a small example of that, that the plans are starting to reach out in different ways to the provider community. On the flip side, the providers are realizing that as good and as sophisticated as they may be, that in a vacuum on their own, they really cannot provide the high quality value-based care in a vacuum. They need strong payer relationships to help them either have the infrastructure, get the data, be able to partner, get the reimbursements and recognition for the work that they're doing. That is obviously significantly different than the traditional fee-for-service business model that's been out there forever. And so those two are, I think, the big drivers. The plans have very limited headroom now as the reimbursements get ratcheted down and the money in the system becomes more compressed. They have to have these new relationships, and hopefully it will, and I think it is, starting to drive performance and smooth out some of the relationships and the tension between the physicians and the payers.
Exactly. I think what I'll do, I'll have Chris go, and then I'd also like to hear Kelly's response because I'm sure she has thoughts. But Chris, any thoughts on a nationwide basis?
Yeah, absolutely. I think, in order to, building on Jeff's point, in order to deliver high quality care, I think we're finally starting to recognize and be proactive in acknowledging that the only way that you do that effectively is by bringing behavioral health into the mix. For the longest time, they've been carved out, or you treat behavioral health somewhere and then physical health somewhere else. And, it's just health, really. We know that. I mean, think about how many people have chronic conditions, diabetes, hypertension, chronic pain, and also have depression that we know impacts the utilization of the system and your outcomes, yet just goes untreated or unidentified. And it's unrealistic to expect every primary care provider to have a on-site LCSW or professional. And so I'm sure any provider that's listening is saying, well, I'm already expected to do too much in the course of a day. I don't have expertise here. And so, how to incentivize asking for consultations and doing more measurement-based care so you can identify those proactively. So there's a number of things related to new CMS codes that have been unbundled related to collaborative care and behavioral health integration and in capitated arrangements, right? We see RAP scores related to Medicare Advantage being lower because people are unidentified. And so getting the right resources to the providers, standardizing that care and providing that data back to payers is paramount when it comes to behavioral health integration.
Wonderful. Kelly, now actually two whole areas that you could respond to. One, what Dr. Bailett said, and then of course, Chris introduced the important topic of how behavioral health is integrated into all of this.
Thanks, Mark. Yeah, I think that the payer-provider partnership is absolutely critical in order to achieve the right health outcomes for patients. And really, that's at the end of the day, that's what we're all here for. I think that each entity plays a particularly important role. As Jeff mentioned, the payers are never going to be able to be close enough to the actual provision of care to have as meaningful of an impact as physicians can. However, physicians on their own in their practices need a lot of support. And with prices being ratcheted down and quality expectations being higher, consumers being very savvy and expecting, excellent service for high value, it really takes a village. And the partnership and closeness of the payers and providers is critical, but even they can't do it alone. It also takes technology and partners, behavioral health, pharmacy, some of the areas that fall outside of the traditional physician office and hospital setting, to really get enough data to be able to predict, to prevent, and to provide that support and total value of care.
Exactly. Thank you. Well, that segues beautifully to Dr. Peel. I was going to use the word data. I was going to ask you, Dr. Peel, what you think the biggest challenges are, but clearly, and you and I have been discussing this for a while, so I can reference past discussions, clearly the data challenge is one of the big ones. But what are the biggest challenges right now to the forward evolution of payer-provider collaboration in your view?
So thank you for the question, and thank you for the panelists' already insightful comments around this space. COVID has done what we have not been able to achieve for decades in this country, which is put digital on steroids. But as COVID, so that's been one piece. Why did it do that? Why were the hospitals there? Because COVID put a ton of pressure on hospital operations. And so hospitals' revenues dried up under COVID, unless they were in value-based payment arrangements where they were continuing to be paid, even if they weren't actually brick and mortar seeing the patient. So there's been a real push here to try to crowd out brick and mortar, move to value-based payments on this. And what that has resulted in, not quite what you asked, but I'm going to go there anyway, you know I will. What that has resulted in is this big push into digital applications, both from entrepreneurs. Oh my gosh, the entrepreneur space is bubbling all over the top of it because CMS is now paying for it. But it has done something very bizarre to what we have done, which is in brick and mortar, you doctor, how do you deliver your medicalized services? Somebody gets on a road, on a bus, on a bike, they walk, they get on a road and they drive to your brick and mortar services and they park in your service lot and you deliver brick and mortar services. Who owns the road? The public. Those are taxpayer dollars that maintain the road. When we move to digital, how do they get to you? Internet or cellular data. Who owns the road? That is all privately owned. That is a private competitive market. So one of the pressures that we see here are disparities in access that are actually coming behind the innovation we've wanted for so long.
Yeah, absolutely. And one of the areas I want to, and I certainly would love your perspective, Dr. Peel, on this and everyone's, but I'm going to go to Priscilla. Priscilla, what types of trust issues and contracting issues are starting to be worked out between payers and providers here? Because clearly at a certain point, the rubber meets the road, and whatever we might say at some high kind of Olympian level has to be worked out. How do you see things being worked out?
Well, I think that everybody has come to the realization that having data to be shared is going to be valuable for both organizations, right? So payers are looking for ways to keep their costs down and to ensure healthier clients, and physicians are looking for ways to get more information about their patients in care providing in settings that are outside of their practice. So as the payer, you're the be all end all of any treatment that was performed, whether somebody's in Massachusetts or in Florida. So you're getting that data, and then providers are seeing the patient. So I think we've come to the realization that combining our resources is going to be in the best interest of the patient. And as it being in healthcare, that's what we're all here for. So could you call it the greater good? It's a prevailing philosophy that we're all in this together, and whatever political issues that we have, we really need to get to the bottom of them, because we need to take care of patients first and foremost.
Absolutely. So Dr. Bailett, and then I'll also go to Priscilla, and then everyone else can certainly jump in. Let's talk about the actual mechanisms and tools that we need. And obviously you're right in the middle of that in your work to move forward. What are some of the core areas of data sharing and analytics work that are being explored right now, including by your organization with Kelly's and others, where we're starting to make real progress in this area?
Well, as Priscilla said, data sharing is critically important. And historically, there's been a lot of challenges with that, a lot of trust and lack thereof that has prohibited the sharing of data on both sides, from the payers going to the provider community and vice versa. The providers are fearful that the information will be weaponized on the next contracting cycle. And the plans obviously desperately need that information for things as simple but important as HEDIS requirements. And HEDIS, I think everyone knows, stands for hell every day in spring, because the payer community, and Pamela, I saw her chuckle, everybody runs around to try and get their reports, their HEDIS reporting, and because that's how we get paid. I'm not saying it's a beautiful thing. I'm not here to endorse HEDIS, but it is what it is, and we need to abide by it. But more importantly, data can be a very powerful thing if it's real time, if it's actionable. And right now is Pamela and Priscilla have said, the innovation is being unleashed. So the predictive analytics, as a physician, as a clinician, if you can tell me with the patient in front of me or my population of patients, what's going to happen with them and what I can do to intervene that can avoid those outcomes, it's incredibly powerful. In my former medical group, we used predictive analytics for heart failure and looked at patients who had a 90% or greater chance of being admitted in the next 6 months for heart failure related issues. And we were able, with predictive analytics and clinical redesign, we dropped the heart failure related admissions by 60%, 60. That is continuing to be sustained. That is a tremendous impact. And when they reanalyze those patients, their score was actually improved. So they actually, their health status improved with that clinical redesign. So those are the kinds of powerful impacts that we can make if A, we work together and get the data where it needs to be, and then B, gets the innovation layered on top of that data to present it to the clinical community in an actionable, relevant, real-time way. And it's not just the clinicians, it's also the patients.
Yeah, I actually think every panelist here will have something to say. So let's go to Priscilla, Dr. Peel, Kelly, and Chris. I mean, Priscilla first, and then anyone can jump in.
Well, I think that, we spend so much time collecting this data, right? All the providers, all of the payers, and it may not sound very exciting, but where are you putting that, right? So what we see in the field is that people are in need of a reliable data repository for this clinical and claims payment information. We've had a number of conversations with our hospital clients where they have tried to deploy a storage infrastructure and it becomes unreliable and data is lost. So when we're talking about this evolution of data collection and analysis, what I see on the back end is what is holding this all together and what is the technology that we're bringing out into the industry, which allows people to take this data and analyze it quickly and efficiently and not lose any of it, because everybody's spending so much time putting the data into the system. And the reason we're putting it in is so we can get it back out again. So if we don't have the infrastructure underneath the data collection, there's nothing we're going to be able to do about it once we collect it. So that's what we're working on at Pure, is providing a reliable base level for this data so that people can continue to utilize it. And like, Dr. Bailey was saying, he's making predictions about people's health based on the data that's being collected. So it's the reliability, which should be a concern for everybody, because it's precious. You don't want to lose any of that you've collected.
I know our other three panelists have thoughts. Dr. Peel, I can hear your thoughts.
You can hear it. I'm burning on this. So let me go back to our fundamental question that we started off with, Mark, which is why the payer provider? What is going on now in the payer provider space? Priscilla made an extraordinarily good point here. The provider overwhelmingly sees what goes on in their space, their clinics, their hospitals, their space. They do not see Susie Sunshine when she shows up in the emergency room in Boca Raton, when her home base is San Francisco. Only the payer has the 360 view. Yeah. Here's the power, which Priscilla was speaking to. Here is the power of the payer provider. The data are the power. The data are where, that's our eyes. You can't manage what you can't see. Mm-hmm. Data allow you to see. But if you're the provider, you only have a partial view, unless you're Geisinger. If you're a provider, you only have a partial view. Hence, that's forcing payers and providers together. Payers want providers to manage this financial risk. Providers can't manage what they can't see. There's the intrinsic force that brings it together. Here is what is going to rattle this industry in data, besides storage, correct, Priscilla? It's going to rattle this industry is a lot of the data that providers have is A, not normalized, and B, it's free text. And it's sitting there in Epic, Cerner, Allscripts, whatever hell. That's why you're trying to get your data out of it. NLP is what's going to come in and start changing this industry to allow us to use data without having to take and extract it and turn it into structured data, which we haven't even agreed on the definitions yet, and then try to act on the structured data. So I do think that there are several small startups in this space around NLP. They are going to potentially really disrupt this environment.
Wonderful. I know Kelly and Chris, I know you have thoughts.
Sure, perhaps even to bring another perspective into the mix that Pamela just touched on. payers and providers, you typically see better collaboration when there's risk sharing involved. So that the data sharing becomes required in order for the parties to adequately manage the risk. And there tends to be a stronger focus on the actual outcomes and expectations when there is risk sharing involved. And so I think there's actually 3 layers in here. There's the payer to the provider organization, and then the provider organization to practice. And so when we look at data, you know, the more risk you take, the more control, direct control and ownership you need to have of the data. For example, provider groups, if you're taking financial risk, should be paying the claims, should be providing the utilization management and prior authorization services. So there's that level of data sharing between the provider group and the payer. But just as important, if not more important, is the real-time data sharing between the providers who are actually giving the care, whether that be the hospital and getting direct data feeds, EHR data connected with claims data, so that you can match the claims and the clinical data. So what's in that free text of the EHR along with the claims, so that you really have that big repository of all the information together. That's what allows you to then get into the predictive analytics.
Yeah.
And what we've seen through the years with Brown and Tollen's history is taking risk for so long is, I think that in particular, California, I think, is a really good role model for this, because the HMO product has been capitated and risk-based for so many years. There's a lot of learnings and successes in that could be applied to other products. So the world's kind of moved beyond HMO, doesn't really like it very much. And so what we found ourselves in is ACOs and PPOs, but that same level of data integration and sharing has not existed. And so I think as the industry and the country is moving more towards that value-based component in a fee-for-service environment, how can we take some of those learnings that have proven to be successful and apply them to other products?
Yeah, absolutely. And we talk so much about marrying clinical and claims data. I sometimes feel like we're talking about wedding planning or something like that in healthcare. Chris, I know you had some thoughts.
Yeah, well, Mark, you actually teed it up. So we're talking about clinical, the 2 data sets, clinical and claims data, which are immensely powerful. I mean, claims data is very predictive. That's what happens when someone shows up to the ER, maybe they have a depression diagnosis, they get enrolled in a chronic care management program or a care management program, they're flagged as high risk, and then somebody telephonically reaches out to them every so often to make sure they're, getting the appropriate type of care. What we found is, and to Pamela's point about putting, digital on steroids during COVID, remote patient monitoring has been a key part in proactively gathering a lot of this data so that care managers, nurses, and providers alike can be proactive in reaching out to rising risks before they show up to the ER. And when you do that effectively, and you don't have to staff a big call center with technology, because you can automate a lot of this member engagement remotely, you identify those risks so that you can provide them the right resources at the right time. And we've shown with a number of our partners huge reductions in ER utilization. The vast majority are not primarily behavioral health related, and I think that's proof is in the pudding in terms of being able to engage people where they are, not just when they're in the clinic. Using that data that you're collecting to get a longitudinal picture, not just a point in care when they come to see my physician or when they drop an expensive claim. You can be more proactive in treating the whole triangle, not just the top 5%.
Absolutely. So all panelists, where are a few areas where we're making the most progress in this area right now? And where are the areas that are turning out to be the most difficult? Who would like to leap in on that? Dr. Bailett, I know you are.
I'll pipe in on that.
I was going to ask you, Mark, if you could clarify. I'm sorry, could you clarify that question?
Yeah, from your viewpoint, and then we'll have Dr. Peel leap into in what areas of collaboration around data are you making the most progress right now, you and others that you can observe? And where are the areas that are the most difficult to make progress in terms of care delivery, improving outcomes, et cetera, using data collaboratively?
So I would say the place where we're making a lot of progress right now is around real-time data. So I believe it was maybe Priscilla or Kelly who commented on the need for real-time data, know what's going on. We scrape Cerner and Epic, the two EMRs that we use at UPMC predominantly. We scrape them in real time, Mark. In nanoseconds of the time somebody has entered a note into either one of those systems, and we store it in AWS. We don't do anything to it. We don't glue it together. We don't anything. We run NLP over the top of it. And we are looking for things that, to Jeff's point, things that we know are predictive of the future bad juju. And then we are pushing out to our physicians, to our practices. Miss Sunshine was in the ED yesterday for this morning. Miss Sunshine's in the ED as we speak. We actually have an app that does that. And she's presented for an ambulatory sensitive condition. Get her out of the ED and do something about it. So we're making a lot of progress in real-time data. We are having more trouble pushing the data back to the doctors. We can grab it, we can do our predictive magic with it, but we have to inform the physician and the practices, and we have a lot of them, of doing something with that. Plus, there has to be some base investment. I believe it was Priscilla who commented on where's the infrastructure that supports storing the data, doing something with the data. Who's paying for that? Is the provider paying for that? Is the payer paying for that? Is the government paying for that? Who's paying for the infrastructure? What we have stood up to date will not support where we aspire to go.
Yeah, good points. Dr. Bailett, does that help you? What are your thoughts?
That helps. And, as Pamela said, there's a lot of bright spots, but I also think it would be, I just think we need to point out that there are a lot of challenges with data sharing and a lot of reluctance to data share. Quite honestly, here in California, we have several HIEs that are repositories for data. The plans have invested in one of them. There's others that are provider centric, but at the end of the day, there's still a lot of reluctance among the provider community and frankly, even some of the plans to share their data. There are challenges with sharing data. It's not always accurate. It has to be cleaned up. There needs to be data governance. And I'm sure Pamela's lived in that world at UPMC. But, as I said earlier, there's a lot of concern and sometimes it's justified on weaponizing the data and how are you going to use it? And security, my goodness, if everyone knows that's where all the data is, they're going to go after it, rightfully so. And then the last point that I'll make around this is workflows. Even if you've got it all cleaned up, how do you deliver the data to the clinical community in a timely way that's relevant, actionable, and doesn't blow up their practice? So they are working with their patient in an exam room or virtually, and all of these pop-ups and messages. How do you get the information to them in a way that they can actually use it and it doesn't disrupt their workflows? And there's a lot of innovation in that space.
So
exactly.
So Jeff, I think it was you who said this. Progress will be made at the speed of trust.
Yes.
And that is absolutely, the payer and providers have to trust each other, not to turn on each other and weaponize the data or use the data to observe that somebody else pays them less for some service. Therefore, we're lowering your fee schedule. So progress will only come at the speed of trust. That's not my, I think that's Jeff's quote.
Yeah, great. Kelly, how do we do this so that we don't blow up physicians' work lives? They already feel so burdened. They already feel they have to pay attention to so many things. The average physician just kind of feels overwhelmed.
Yeah, well, it's interesting. And I think in particular for the independent physician model, which is a little bit different from an integrated system, is there's a lot of benefits to it, but there's also some extra challenges in that how do you share all that data back and forth when everybody's not on the same system? So I think that there's a few things. I'm going to go back again to the financial piece of it with incentives and risk sharing. I think that the parties come to the table and share in a better way when everyone has some skin in the game. And what we find to be the most successful relationships with payers and with our providers is when we are we're in it together. We're sharing the upside and the downside of the outcomes. whether that's with the payer or incentives that we can target directly with our providers for what they need. As far as how we support the physicians, that's actually one of the main reasons that we partnered with Alteus when we just closed that transaction back in November, is that Alteus is being built around tools. While Brown and Tollen has a management services organization, we know how to manage capitation and all of those types of things. What Alteus has been working on are tools that actually work in the practice, in the day-to-day lives of the physicians, and how can we increase the communication flow between one provider to another, between providers and the patient, and how can we have more real-time data sharing to make their lives easier. So we're excited to be working on some of those tools with Jeff and bringing some more relief is the word that comes to mind.
That's terrific. Thank you. Priscilla and then Chris, let's talk about data infrastructure to support this. Dr. Peel just talked about how hard it is to for plans to then take data back to providers. What are some of the challenges right now to data infrastructure for the architecting of data infrastructure to support all this work?
Well, a lot of what we see in the payer and in the provider community is talk about the cloud, right? So there's a lot of pressure to be going to the cloud. Executives feel like they should be going to the cloud, but then a lot of the data is not really well suited for the cloud. So what we've been able to develop at Pure is what we call the hybrid cloud. So you have data, and our philosophy is we're going to put that data where it benefits the organization the most. So some data can go in the cloud, and there may be efficiencies up in the cloud that you're not receiving on-prem, and vice versa. So I think it's important to look at the actual data that's being collected, what it's being utilized for, where it needs to be accessible, and then make decisions about where you're going to put it that makes it the most actionable as well as most cost efficient for the organization, because it doesn't need to be expensive and be all consuming if you're clear about what you're utilizing it for. And not only that, where are you going to take this in the future? Is this something you have a 5-year plan on? I don't know that data can be examined at one point in time and make infrastructure decisions around it. It has to be part of a bigger plan. So we like to try to help our customers have those conversations and to ensure long-term success, because as we all know, healthcare changes every minute of every day, and trying to be ahead of the curve, we think is helping some of our customer organizations with that.
Yeah. Chris, how do you see the infrastructure issue?
Yeah, I think that the main challenge is not just collecting the data and analyzing. I mean, that's obviously the first piece of it, but then it's the so what afterwards, right? We collect all this data, and what we hear time and time again working with primary care providers is, I already have too much, or I don't know what the right next step is to do with that patient. And even if the right next step is, say, a referral to a psychiatrist or medication management type situation, when the patient leaves the clinic, well, then what happens, right? This lost referral, and then there's a huge data gap. And so the only way that we've gotten traction successfully with primary care providers and other specialists is having to integrate into their electronic health record. Otherwise, it's just too much work and they won't adopt it. Change management is too big of a burden, and they have too much to worry about. Asking them to log into another platform is just not realistic. And so doing our best to make the data ubiquitous throughout their workflow with tangible next steps, just easy to bite off chunks based on, this person is mildly depressed in addition to their diabetes. They don't need to go see a psychiatrist versus this person, is in a really bad situation. And providing that right in the EHR. So it's a easy from a workflow standpoint.
Great. Kelly, how do we make things easiest for physicians in their workflow while giving them things?
I think that what we find in the independent practice setting is that the more we can normalize between payers and products so that they don't have to worry about multiple sets of rules, multiple reporting requirements, multiple, deadlines or workflows, it should be one workflow that applies to all. And so that's the value that we try to bring to them is to normalize that, that we do that on their behalf with all of the payers.
Wonderful.
I think that's important.
Great. Dr. Bala and Dr. Peel, what are some of the best practices that are starting to emerge as we do this work?
I'll take what I think is an example of a good practice as we do this. We at UPMC have moved several of our expensive pharmaceuticals into a payment based on patient-reported outcome. It's a pretty novel idea. So we did this first around an MS drug. We've expanded it to maybe 5 or 6 drugs now. So we will pay the pharmaceutical a base amount, and then depending on the patient's self-report, when they show up at their doctor, they just fill out a little one page, the patient self-reports. The patient doesn't know that that is influencing what the pharmaceutical company is going to be paid. If the patient reports that they are better, then we pay more for the drug. So we're tying the actual amount, the amount of reimbursement to the amount of the patient reported improvement or not, which I think is very much where we've struggled for years here, Mark. We like to talk about value-based payments.
Yeah.
We don't even know what we're talking about.
Yeah.
Whose value are we talking about here? So I think that that's one of the more innovative things we've done.
No, I think that's great, Dr. Peel, because I think what you're speaking to is where is the locus? Like what lever do you actually press to make something happen? In healthcare, the value chain is so diffuse, right? Like how do there's that silly commercial, I think from Office Max or whatever about the easy button. Well, there's no easy button in healthcare. if there were, somebody would be a trillionaire by now, right? Dr. Bala, your thoughts on that?
Well, just taking off on Pamela's pharmacy example, we've been able. There's a company that we're working with and it's a California. It's across California, but as a doc prescribes a drug for a patient, it has their historical prescribing patterns and habits, but it also is aware of what that patient is going to see at the window when they go to the pharmacist. Yes. As a physician, I can tell you that I would write prescriptions for my patients I saw in the morning, and then my staff would be answering phone calls because it's the sticker shock when they get there and find out that their out-of-pocket expenses. Really, I'm just for a tube of dermatology cream, I'm spending $120, not so fast. So this particular technology flashes to the doc, hey, here's what you've been prescribing in the past. The cost is going to be different to the patient if you prescribe these alternatives. And what they've been able to show is it's decreased the pharmacy spend by 5%.
Yeah.
Blue Shield of California spends $2 billion on pharmacy expenses. So 5% is real money. And wouldn't it be nice for those dollars to be redeployed to help physicians in Brown and Tollen or other clinicians in the state to better manage their patients and maximize the health and well-being? That's really, and that's just a small piece, Mark. I could go on about the kinds of technology, but since Pamela mentioned pharmacy, I thought that would be a good one.
And that's a really important point, Jeff, because we do the same here. For our UPMC employed physicians, we push to them at the point of prescribing. Yeah. What is this member? This is a UPMC health plan member in front of you. You just prescribed red fairy dust. Given their copay, their deductible, and where they are in their benefits, this is what it's going to cost this patient out of pocket when they show up. By the way, green glitter works almost as well. And green glitter is a fraction of the cost of red fairy dust. We're not telling you what to do. We're helping you have a conversation with the patient, including the fact that we did a little study, I think it's fascinating, of people who have incident AFib. So their first diagnosis of AFib, they go to see a cardiologist. The cardiologist prescribes an anticoagulant, which is a standard of care for AFib. Fully, Mark, 30% of those patients never fill their anticoagulant.
Yeah.
Cardiologist has no idea.
Mm-hmm. Yeah, exactly. So what I'm going to do now, we do have audience questions. So what I'm going to do is I'm going to ask, I'll give each panelist the opportunity. If you don't want to, you can pass. But tell us what's going to happen in this area in the next 2 or 3 years, and you can take that in any direction you'd like. I'll pick Kelly first, just because.
I think we've touched on it a lot through this conversation, but getting to as much data as real time as possible is what's going to have the biggest impact. And I see that that's where everyone's focus is. And so I think that with everyone driving in the same direction, that's where we're going to start to see more of an impact.
Great. Dr. Bailett?
Kelly touched on it early in the conversation about the disparate pockets. Not everybody's on the same platform. Not everyone's on the same EMR. Even if you're on a particular instance of Epic, if you're not on the same, they don't always talk to each other. And now we have this virtual telehealth, and thank God it was there during the pandemic. But that in of itself, if not controlled, is going to be another silo of all of this data that's coming through the telehealth world. And so we need to figure out, and again, I'm going to say it, it's easy if you say it fast, interoperability, Mark. That is the biggest challenge. And I think, there's been a lot of conversation and happy talk about it, but I think until there's some mandate, and I am not a big fan of mandates, but until there's some injection of discipline into the system that we have to have interoperability, then these systems need to talk to each other. Yeah. We can't unleash the innovation and the kind of predictive analytics that Panelist system is blessed to be able to do, because they have a plan and they have the provider organization and they partnered. Unless you have that, you can't really unleash that kind of innovation in predictive analytics and all of the other kinds of information you can garner from that data to change patient outcomes.
And I'll just say, Dr. Bailett, that what you just pointed up, there's this huge conversation in the healthcare IT policy sphere on how do we create true interoperability industry-wide. So you're on top of it. You're on top of a big conversation. Dr. Peel?
So I think one of the things, and I noticed in the chat I wanted to speak to, somebody brought up the question about what about the failed experiments in Health Vault and Google Health when we tried to empower patients to own their own data. And I think that we are not going to go back there, and here is why. We turned the fire hose onto people. We have data. You want data? I got so much data, you can never wade through it. And you want me to put this data into Mark's hands or my hands or somebody else's hands, and it's all in medical lingo? It's not useful. So until we come up with a way to distill down the salient pieces that an individual patient needs to know and understand and serve that up to them, then turning on the fire hose is not going to do anything. There are some startups in this space that are trying to use NLP and voice recordings to go through and pull out the salient pieces of an E&M, of an office visit, and serve it back up to the patient, both recorded and in summary. That might work.
Okay. Chris, what's going to happen in the next couple of years?
I think that I'm optimistic for what Kelly said needs to happen is more real-time data and collecting that. And so, Pamela said she's doing patient-reported outcomes. I love that, I think, but being able to collect that more than just when you're in the clinic and doing that through different sorts of discrete type of data. So passive collection, right? We collect wearable data so we can track exercise levels. And normally if Chris exercises 4 days a week and I stop, that's a signal of maybe something's going on there that could be a risk factor. Natural language processing on not just provider notes, but on patient journaling and patient notes that they write to their providers. Doing those sorts of real-time data collection and then providing the resources as quickly as possible, not waiting for a provider to react, but allowing the provider to have that so they can make a more informed clinical decision when it's time to do that, and using that data to risk stratify so that the right people are getting the right type of care, whether that's medication, a specialist visit, a referral, or what have you, using those resources more cost efficiently.
Okay. And Priscilla, what will happen in the next couple of years?
Well, I like to have hope because I sold software for Meditech for many, many, many years. And 10 years ago, the thought of sharing a continuity of care document with another organization that you might compete with was anathema. I'm not telling those guys what I'm doing. I'm not telling them about their patients. That's my patient. And now we've seen, to Pamela's point, it's all about the structured data. So we have been able to codify a number of the data points that are meaningful for physicians and providers. Even lab results can be a great indicator of a patient's outcome and what their status is. So I look back 10 years and say, we said we were never going to do it then. And maybe in 10 years, we'll look back in 10 years and say, oh, remember when we would never share our data with the providers? Oh, that was the worst time. So I think it's possible because we've done it before in healthcare. And I think that's just the future. And we'll get there eventually.
Thank you. So we have 3 questions from the audience. Though I'm going to take the first one because it's the most specific and it's addressed to one person. So Dr. Bailett, someone asks, what do you think is missing from ONC's final rule on interoperability? Isn't this the beginning of what you're asking for? That probably puts you a little bit on the spot.
Well, it does, especially since I'm the chair of the PTAC and work for the secretary. So I think, I'd probably be wise, Mark, to pass on that. If that's okay. There's one important point that I think we would be remiss if we didn't bring it up. And that is, value is easy if you say it fast, but it's really difficult to deliver. We talked about that throughout this panel. And unless we have professionally gratified physicians who are not burned out, oh, by the way, that's 60% of the docs are either significantly disenfranchised or burned out right now. They are never going to be able to provide the kind of high wire, high quality, affordable healthcare that they deserve if they themselves are not professionally gratified. So the kinds of tools and technology that needs to be unleashed in the physician community, aside from the data, is tools that really help with their workflow and reduce the burden of practice. We talked about natural language processing. Pamela mentioned some of the tools that are out there to get the physician out of the medical record, if you will, educate the patient before the visit. I don't want to get into all of the detail, but this is really, to me, when you ask what's going to happen in the next 3 years, those are going to be the companies that disrupt the industry, the ones that can come in and put tools in the hands of physicians that don't disrupt their workflow, are professionally gratifying, help them maximize the health and well-being of their patients, and keep themselves, the physicians themselves, restore the practice vibrancy. And I'll just say this, I'm not up for viable medicine. I keep hearing that across the industry. Hey, doc, I just want to remain viable. To heck with viable. I want vibrant medicine for me and my family, and that needs to happen. And I just felt passionate about it and thought it was an important point to make today.
A great point. Thank you. Other question? Oh, sure, Dr. Peel, go ahead.
So yeah. I think back to this point about tools that help providers practice in a more satisfying way, to Jeff's point, that means that we need something that's not a separate platform. Chris brought this up. If what we have to do is go out to a platform that's not your EMR platform to get information, to do something, to tell you who to do, blah, 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 and then come back into your EMM platform, it's not going to work. The lack of interoperability is actually a gigantic barrier to moving forward with the types of insights that all of the panelists have spoken to.
Thank you. Thank you for that point. Last question from the audience. Is there a method to convince patients/payers to adopt cash-based healthcare solutions for some select specialties, especially in telemedicine? I'm not quite sure where the audience member is going, but whoever would like to grab that.
I'll pick it up. I think if this is where I think they're going, which I could be wrong, if what they mean by cash-based is that the patient and or their family pay out of pocket outside of any insurance structure, either government or private. Here is the thing around using telemedicine in a cash-based piece. Telemedicine has been around for decades. Everybody knows that. We did it on rotary phones, for God's sakes. It's been around forever. It works. There's numerous studies that show that telemedicine works, particularly in congestive heart failure. Why can't we get it off the ground? Because lots of people get value out of it. So you get value, your parents get value, your neighbors get value, your spouse gets value, the kids get value. God knows the physician gets value. Lots of people get value, but we don't sell it by the slice. This is a loaf of bread. Lots of people get value out of a couple of slices of that loaf of bread, but we don't sell it by the slice. We sell it by the loaf. And nobody gets enough value out of it to pay for the entire loaf. So until we figure out how to attribute value and sell value, I don't think we're ever going to see much uptake in cash-based.
Okay, that makes sense. One last thing, I think I want to go back to one question that the attendee asked that Dr. Peel answered a large part of it, but they also asked, do you think that what happened with Health Vault, Google Health, et cetera, was a case of the right approach with a failed implementation? Should we be exploring this option again, perhaps leveraging blockchain or some other foundational technology? I guess my basic question to the panel, and we only have a minute, so whoever would like to leap into this, do you think that there is a future for the personal health record, or do you think it will come about in a different way? My spoiler alert, I think it will come about in a different way through apps, because I think, no one wanted to manage the personal health record. That was why it failed, honestly. The physicians didn't want to manage it. The hospitals didn't want to manage it. Some plans did, but then the members didn't really trust their plans to do it right. So it was never in a good place. Does anyone think that, what does anyone think, if anyone has a quick thought? I guess it was just too stunning a statement. Well, I just want to say,
Mark, I think you're right. I mean, I think that it's a hot potato, and until, and you're right, it's going to be a disruptive. There is definitely, as a patient, as an individual, if someone could tell me that, if you keep doing that, the likelihood is you're going to have a heart attack in 4 months. Right. That'll get my attention, right? But the system isn't designed right now to manage that. But guess what? Technology will get to the point where that will become seamless. It's just not there yet. There's a lot of tracks that have to get laid, like interoperability being one, before we can get to that next level of sophistication.
And my own intuition, even though all of you are smarter than I am, so I could be wrong, is that the app world will somehow create some kind of reality that floats above what we have right now. And I don't know how that will happen, but somewhere in that layer, people will be able to insert pieces, and then providers and plans and everybody will be able to connect. But the way EHRs are set up as they are now, it's just too cumbersome. And I know of personal experiences of people I know personally who are just livid about how their health system has given them a PHR and there's nothing in it. Right? Like, here's your PHR, and there's like literally nothing there. So we have to figure out a better way. Well, I just want to thank everyone. We are literally out of time here. You've been an amazing panel. We've really been able to explore a lot of territory. And I will end with my favorite quote from 2,000 years ago, the Roman orator and senator Seneca, who said, the gods guide those willing to change, those unwilling they drag. And I know no one on this panel is going to be dragged, but it's a very painful thing to be dragged. So I hope that we can move forward in all of these areas with alacrity. Thank you all so much. You've been terrific.
Thank you, Mark.
Thank you.
Thank you, everybody.
Mark. Well, thank all of our panelists that participated, as well as all of our attendees, for all the great questions. We didn't get to some of those questions, but I will send those to the panelists and have them get back to you if they have an answer. Thank you as well to our sponsor, Neuroflow. Appreciate the support. Don't forget to join us for our next sessions, which begin in just a little under an hour. We have a great conversation happening about top hospitals and evaluating trends this afternoon, and then we're wrapping up our day with another great panel discussion. So we're all there for our last session today. Thank you again, panelists. Have a wonderful day. Thank you, Mark, and we'll see you all in the session. Take care.
Thank you all.
Bye.